What I'm going to do, I don't know whether you have seen my presentation before, but I I, I will just decided to rather to go through. Somebody has got speaker on. There's a noise behind it. Can we just see? Can you turn that off? Okay, thank you guys. And then I thought I will just go through 3-4 cases with you, and it will be interactive session, and that cases will cover 4 areas of stroke care, which is pre-hospital, like primary care, TIA. Then we will have a case of secondary care related, and then we have a case for thrombolysis related or secondary stroke prevention. So what I'll do is I'll just go through. Ideally, I would like to do interactively where we can talk and chat, but I don't think you've got all the speakers available to your own your computers. So what I'll do, I'll start off with a case, and then what we'll do is I'll give you option, then we discuss it, and then we go through these 4 cases. Okay. So the first case I will present to you is a 60 years old gentleman, fit and well. He presented to A&E with excessive expressive dysphagia, which recovered within 24 hours. And the questions are, what would you do next? I'll give you options, and then we'll have a chat. So these are the different antithrombotic agents which we can use in situations like that, and if you suspect it's a TIA. So the solutions, and depending on where you're working in A&E or in the hospital setting or GP practice, you can start 75 milligrams aspirin daily, then you can give them loading dose aspirin then by 75 milligram daily. And if you work in A&E in hospitals, you will have some protocols to that effect as well. You can also use dipyridamole 200 milligram BD if people and don't have any, they can't take aspirin or clopidogrel, for example. Or you can go for D, which means loading dose of clopidogrel 3 milligram followed by 75 milligrams daily. Or you can start aspirin dipyridamole combination, which is 20 milligram BD. Now, I don't know how you can respond to that. Why is going back? Sorry, what is somebody pressing or something? What has happened here?
Oh, no idea.
Let me see. Sharing window or not sharing window with somebody? Who's MW?
That's me. I'm not sharing any window at the moment. Mm. Dr. Rahmani, we seem to have lost you.
Yeah, we're back again. Sorry, guys. Who's me? Oh God, what is this nonsense? I can't understand it.
Anything I can help?
Yeah, I'm on now. Anybody, guys? Anybody wants to comment on what option to go for? Any answers? Any questions? Anything on the chat box or anything? No? Okay, I'll go ahead then. I think there's two options you can go for. You can give a loading dose of aspirin 3 milligrams followed by aspirin 75 milligrams, which is normally you do in patients who's got suspected TIA. Like when you patient, we see them in our A&E setting, for example, and then we move on to refer them to the specialist clinics. We do rapid access TI clinic on our site here with patients within 24 hours, and then we decide what to do. And once it is confirmed, we can then start them on a loading dose of clopidogrel now, the 300 milligrams followed by 70 milligrams. That is for the confirmed TIA patients. Just to give you a background of anatomical classification of TIAs, there are two circulations of the brain. We divide them, and based on their presentation, their anterior circulation and posterior circulation TIAs. As you see at the bottom for carotid TIAs, for anterior circulation, we use carotid Dopplers, and for posterior circulations, we don't go for carotid Dopplers. I think it's very important that we should be able to differentiate between the two. Sometimes it's not easy and difficult in a very busy situation in the A&E, or for example, your busy setup. So usually anterior circulation patient present with visual loss transient in one eye with complete recovery. That can lead to retinal infarction. They're called visual TIAs. You can also have expressive dysphasia, aphasia, and then recovery usually within 30 minutes, not longer than that. That is anterior circulation TIA. And then you can have neglect, and you can have hemisensory loss, for example. Spellings are not correct. Loss, lose, it says. Sorry about that. And the posterior circulation, you will usually look for double vision, vertigo, vomiting. They're very tricky ones to sort of. The symptoms are usually not very clear cut, and you can have ataxia, semisensory loss, and loss of consciousness is very rare. It's very important to remember that TIAs, anterior posterior circulation, usually or maybe almost always never present with loss of consciousness or syncope. When somebody presents with syncope, you must consider cardiogenic cause first before thinking about TIA. And then quick evaluation we tend to do in TIA patient, you can do wherever setting you are. You need to make sure characteristic examination is the most important part, I think, because when they come to you, they usually have sign-free. So you basically check your blood pressure, which is one of the vascular risk factors. You check pulse and do ECG to make sure there's not any defibrillation, and you check urine to make sure there's not diabetic, for example, we can reduce risk of stroke and TIA in them patients. And the rest of the scan, I never perform CT chest on these patients. You can do ECG to make sure there's no ischemia. CT brain scan if you think it's indicated, or you think it's something other pathology needs to be excluded. And you can do carotid Dopplers if there's anterior circulation TIA is suspected. So this is just a quick sort of examination for patient who has got a TIA. This is symptoms usually resolve in TIA. We used to have a previous ABCD scoring system, which we normally don't use now, but only benefit of that is that TIA usually resolve within 24 hours. And if the score on ABCD, there is a argument for admitting them if they've got a very high ABCD score. If you see on the right side, if the score is higher, your second day, 7-day, 30-day risk increase significantly. So patient who's come to hospital, it is important you can decide whether patient needs to stay in the hospital or can be discharged home. On the graph you can see, on the table you can see here, if they're scoring high at 6 to 7, you may admit in the hospital. If the development of stroke, you can thrombolize them. This is the score I was talking about. This score is not used normally now. It used to be used in the past, where we define high risk and low risk patients based on this TIA scoring system. As you can see here, if you got a high score, high blood pressure with symptoms lasting more than, depending on the duration of symptoms, and diabetes, you score them accordingly, and then you can aggressively either treat them or admit them in the hospital. But the latest guidance states that you should admit or assess and treat patients who had neurological symptoms referred to you within 24 hours, irrespective of the score is. So that has changed recently. And the answers which I gave you came from these guidelines we got. The patient is presenting with suspected TIA, you give 300, as I said before, and you must refer them to 24 hours, within 24 hours to be seen in specialist clinic. We got our TIA clinics running here in the hospital at Conquest. You can see only slide 3. I don't know why.
Yes, it's not moving, Dr. Rahmani. It says you're on slide 9, but I can only see slide 3. I'm not sure if
Is the
everyone agrees
management of
with me.
TIA slide there?
I can see what I can see is solutions from A to E. Start with aspirin, loading dose, all the way to start aspirin and a dipyramidamol combination. That's what I can see. Slide 3.
I don't know which slide is this. I'm management of TIA.
You're on slide 9, according to my top bar.
I don't know.
Let me just see if I can move this. So, oh right, I can move it from my side. I don't know if the other guys can see what I'm moving.
So I am just doing the 3.2 management of TIA.
Right.
Is everybody seeing this, guys? Anybody can tell me?
Management of TIA.
I can see that.
3.2 management of TIA.
3.2 management of TIA. Yes, we can see that.
Okay, this is the slide. Yeah, we carry on with this one then. Okay.
Yeah. Okay.
Can you not fiddle, please, with anything? I will lose it. Yeah. I don't know why you go to that one, but anyway, sorry about that. So yes, okay. So we move on to this management of TIA, please. Yeah. So patient who had a suspected TIA, as I said before, should be given 300 milligrams of aspirin and then should be referred to a clinic. And if the TIA has occurred 7 weeks ago, then we see them in 7 days, and it should be assessed with the CT scan. I tend to get CT scan done for every patient who come to my clinic, but some consultants do it without. But nowadays, everybody with TIA gets a TIA. And patient who cannot be seen within 7 days. So sometimes we go for MRI scan. MRI scan is a better option for TIA patient. We do perfusion scans now, but I think for practical purposes, they should have CT scan done first before we can start treatment on them. And once we have got a clinical confirmation, sometimes CT scan is normal, CT scan confirmation diagnosis, we give them high dose, 300 milligram loading dose, and then we keep on giving them 75 long term. And high intensity statins, which is 20 to 80 milligrams. I tend not to use 80 milligrams because it can cause liver dysfunction and hepatotoxicity. But if you have to start it, then you need to make sure you monitor the liver function test as well. And you can use blood pressure monitoring therapies, whatever you give, but I think the evidence comes from perindopril. And also in management TIA, these are the other 2 options you need to look for: atrial fibrillation, treat and control, and then anticoagulation is very important in patient. Anybody with TIA must try and figure out either paroxysmal or persistent fibrillation, and they should be treated with anticoagulation. And finally, carotid evaluation is done in patient who has got stable neurological symptoms, and they should be had a carotid evaluation done. In our trust, we do within 2 weeks, but the recommendations are that within 7 days, we should be able to deal with that. So in TIA patients, you look at 5 things: antithrombotic, you do blood pressure control, for example, you do lipid management, atrial fibrillation, and carotid Dopplers. These are the 4-5 things: antiplatelets, anticoagulation. These are the 5 things you must do. So take-home message from this case is that any patient you suspect TIA, you give them aspirin 300, and then you give them 75 and refer them to TIA services. We tend to see them within 24 hours in our hospital, and then we can take it from there. Okay? Any questions? Okay, we move on to the second case now, where we had a gentleman who's a young lady fit for age. She's having these recurrent attacks of pins and needles in her right arm and left leg and right leg over a period of a few weeks. They are very last for 5 minutes, then they go away. She described the sensation start in the right foot and then over a period of 1 minute spreads like running up her leg to involve the whole leg. So marching symptoms she's got. These symptoms are in the focal in the same area with no mistaken past medical history, nil examination. What would you do next? What would you do next, guys? Options are you start aspirin review in 1 week in GP surgery, refer to TI clinic within a week, and refer to neurologist, and admit to the hospital. Any suggestion, guys? Anybody? Anything? Just say anything. Do you think it's a TIA or a stroke? Okay. I think very good. Why you think admit to the hospital? Dr. CH? Why do you think to admit to the hospital? Okay, you think it's a TIA. In TIA, usually you get negative symptoms. You lose function, you lose vision, you lose power. So do you think this patient is having a marching symptoms, positive symptoms, sensations like positive sensation? She hasn't lost sensation. She's got abnormal sensation. Do you think it's a TIA? Okay. The answers are that two things you can do. You can refer to TI clinic or admit to the hospital. As you can see, these symptoms are positive symptoms. They're on one side and they are marching in symptoms. In TIA, you don't get marching of symptoms. You get loss of function, sudden onset of loss of function. Either you can refer to TI clinic if you think it's TIA, because we do CT scan very quickly within 24 hours. As the gentleman CH said earlier on, Dr. CH, that to the admit to the hospital, your logic was not right. TIA, you can go through TIA service. But if you suspect a tumor in the brain tumor, then you urgently admit to the hospital. So this patient was in fact not admitted to the hospital, was sent to TIA clinic and had an urgent scan like we do for all TIA patients. And then this patient had actually partial sensory seizures secondary to left parietal glioma. So not every patient in TIA is a TIA. You can have a differential diagnosis. Lots of patients sent to our TIA clinic. In fact, one study showed 50 to 60% had non-TIA in sent patient who sent to our clinic. So when you have got a patient in front of you, these are the possibilities. You can have a differential diagnosis and you can suspect TIA, but consider these possibilities as well. In this case, is a seizure can present like a TIA. But as I said, in seizures, usually you get positive symptoms, jerking, itching, sensory symptoms, crawling sensation, and fits, for example. In TIA, you don't get those. And you can also have them sometime infection. In fact, I lady this clinic I saw this morning had a TIA and they thought TIA, but she had UTI treated. So it is TIA can mimic, or infection symptoms can mimic TIA and stroke. This is very tricky on migraines. Usually these patients come in a young age, like 40, 50, maybe lots of risk factors on top of that, smoking and migraine. Similarly, in migraine, you will have positive symptoms. In TIA, you have negative symptoms. They usually describe visual symptoms with flashing lights, zigzagging, for example, or kaleidoscopic appearances, and then associated with headache later on. So that can be a bit tricky. And then tumor, as you just seen the case here, usually younger but older patient as well. Progressive symptoms they get, they don't get sudden onset of TIA. Their symptoms are usually progressive and they develop weakness. In demyelination, you can have symptoms of visual loss and recovery, but in demyelination, you will always have some residual neurological deficit left. So in TIA, you get weakness paralysis and you get better. But if you get weakness and paralysis and demyelination, you will be left with some weakness. So you will have some persistent focal neurology after a neurological event due to plaques. Syncope is usually not due to TIA. It could be cardiogenic first investigation. And I had another chap, a BBC reporter who fell 4 weeks ago, came to my clinic with weakness of the right upper limb, and then we found he had a subdural hematoma, and he was sent for evacuation. And these are the other possibilities which can mimic TIA. But I think whenever or wherever you work or wards, any and anybody comes present to you with neurological symptoms of any sort, you must check blood sugar level. Hypoglycemia is always, by the time you get to the patient, it is always done anyway by the nursing staff. So that is something you must check and exclude hypoglycemia. So from case 2, not every TIA is a TIA. TIA mimics, as I showed you, could be a tumor. And there's one study from Rothwell Group, Oxford, indicated that up to 6% of patients referred to TIA clinic do not have a final diagnosis of TIA. And in our clinic, we did a recent audit where I think we were around 49–50% of our patient referred to us had no TIA. And sometimes GPs refer patient to us to get sort of backdoor CT scan done quickly. All our patients get CT scan within 24 hours. And in fact, when they come into the clinic, if you go to 6 patients, they all had their CT scan done in the morning, see me in the afternoon, get all the medication done, investigation started, and discharge. So we don't sort of hang around and take time to the investigations. Any questions, guys? We move to the third case now, yeah? There's another case for you, a 75-year-old gentleman who in his garden suddenly developed weakness of the right arm and steadiness while walking. He had no headache or vomiting. He sat down, within 3 hours was better. However, on close questioning by her primary physician, it emerged that his weak arm had not returned to normal for about 3 days. His blood pressure was tiny bit of 150/90. He looked well with very mild weakness on the right side. He's diabetic, he's slightly overweight. What would you do next? I can give you the options. Routine bloods, as a GP, you see him first, start aspirin and review next week. Start aspirin, refer to TI clinic within a week. Start clopidogrel aspirin, refer to TI clinic, admit to the hospital. What would you do next? Any takers? Anybody? There are 5 doctors. Very good. Why you think SP thinks admit? Dr. SP, why you think? Sam? Very good. Why do you think D? Very good. I agree with you. SP says Sam think there's a weakness persisting within 24 hours, so needs to be admitted to the hospital. Very good. This is exactly what happened. Admit to the hospital because, as he said, 24 hours later there is a weakness and that needs to be investigated. You can't send him to TIA clinic because TIA neurological deficit would have disappeared. And in fact, he had a CT scan and it showed left anterior circulation primary hemorrhage. And if you would opted for any previous option, then you would have had a problem because you can cause then bleeding on that. So that's the message is that how that you should be able to admit people who has got neurological deficit. And I'm sure you heard all this. This is a Rosier scale we usually implement in A&E resus when the patient comes in. This is when done usually outside the hospital. And Rosier scale is done when they have come to A&E, sometimes to differentiate between a seizure and a stroke. And these are the scoring system they got in place. And if they score more than 0, then stroke is most likely, and they trigger stroke care pathway. So these are the 2 different scales used. This is done in the primary care. I'm sure you all heard it. And this is Rosier scale is done in A&E resus, where they identify stroke and TIA. And you can see here all suspected stroke, like the previous case you had, should be admitted directly to the stroke unit from A&E. And that means that we need to get 80% of the patient should go to stroke unit where they should spend 90% of their time. And acute stroke unit has become an intervention. It shows to improve outcomes in terms of less dependent in 6 months and 1 year and less mortality. So therefore, patient with known or suspected stroke not to be admitted in MAU. This is the national stroke strategy. From this previous case and the persistent logical deficits, the Dr. SP has said very rightly so. Sign and symptoms need urgent brain scanning indicating acute hospital admission. So in future, if you work in A&E, you work in GP land, if somebody comes with persistent logical symptoms or signs, you must admit them rather than sending to outpatient clinic or neurology, or for example to STI clinic, especially when these symptoms are acute onset. Any questions? Okay, well, let's go to the fourth question here, fourth case quickly, which is a 8-year-old lady, usually fit and well, no current medical problem. She woke up one morning and sat with her husband, John, to have a breakfast. He went to get a newspaper corner shop. 15 minutes later, he arrived home to find Annie lying on the floor, unable to move or speak. He remembered seeing the fast and got 999. So, and she was brought to the hospital. What did the stroke team do first? Any takers? Book and routine CT scan within 24 hours, immediate CT scan, speak to John to a certain likely time of onset, speak to John to a certain exact time of onset, or refer her to medics and admit in stroke unit. What are the option or the stroke team should do, you think? Anybody? Has anybody involved with the stroke thrombolysis pathway? Very good. LT is fine. Immediate CT scan, which mean next immediate mean next slot, which we do here. We get people in. Yes, and try to do what? Speak to John. Very good. To try and assert an exact time of onset, don't you think? Yeah, Nathan. So yes, I think you're right, both right. What we need, what we did was, this is what they normally do. As you said, speak to John, very rightly so. You need to not to get, oh, maybe it was 8, maybe 9. You need to try and find out exact time of onset, as close possible to the reality, and it should be less than 4.5 hours. You need to get immediate CT scan. The doctor was right. And then you speak to John and see how long ago she had it exactly. In this case, John knew that he saw her fit and well before he went for, so he could tell. Then the nursing staff normally cannulate and take bloods, and they start the measure blood sugar, as I said, with neurological deficit, and they use a scoring system called NIHSS. This looks at the severity of the stroke, and evidence indicate they've got mold, migrate, and severe. Less than 5, you tend not to thrombolyze them. They're very mild symptoms. Between 5 to 25, it has changed slightly, but for practical purposes, 5 to 5 mean moderate, and above 25 is severe. So somebody scoring 25 and above, they're severe stroke. We normally don't thrombolyze them. Between 5 to 25 scoring system, then he's eligible for thrombolysis. And while the patient comes to resus in the hospital, the nursing staff will start to take all the bloods, and because there's contraindication as well. So this is what they did. You're right. You did immediate. You said right. Immediate CT scan and then exact time of onset. So she went for a CT scan, which showed early changes of ischemic stroke, and her NHS score was 32. And should she be thrombolyzed? I expect you to say yes. 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 Annie was thrombolyzed, and from this short case, it is possible that every suspected stroke with no bleeding on the CT scan with onset of symptom less than 4.5 should be assessed and considered thrombolysis. This is the standard practice now. Every hospital you go and work, you will have a protocol, in fact, or guideline, usually protocol, not guideline, in place for patient acute stroke should be assessed for thrombolysis. And we tend to use to have 2 stroke units in Hastings and Conquest and Eastbourne. And now we got only 1 acute stroke unit. If usually the acute thrombolysis service sits on acute stroke unit. So if patient has got indication for thrombolysis, they will be thrombolyzed in acute stroke unit and will be kept there. If there's a no thrombolysis indication, then they will go and stay in acute ward and get acute thrombolysis care. So in future, you will become like CT or more senior doctors and even FY2, you might come across stroke thrombolysis protocol if you work in hospital where there is acute stroke unit. And these are the indication for stroke thrombolysis. If you have got clinical diagnosis ischemic stroke causing measurable neurological deficit, NHS score, with an onset of symptoms less than 4 hours, 4.5 hours time window may increase in future. Trials are going on, 6 hours maybe, or maybe 8 hours, which means we have to then send people at a longer centralized units for thrombolysis before treatment. If the exact time of stroke is not known, it is defined at the last time the patient was known to be normal. And that is the reason lots of patients who can't have thrombolysis because they get stroke while they sleep. So you take the time when they went to bed or when they were fine and that is usually longer than 4.5 hours. So there are some trials ongoing which are looking at whether we can thrombolyze people who have a stroke during the sleep and whether we can salvage their brain and can thrombolyze them. But for the time being, lots of patients miss thrombolysis because they get stroke in their sleep and they can't be thrombolyzed. Overall age of limit is above 18 years old. I have to remember thrombolyzing a patient a long time ago in 90s, and nothing. Lots of fit 90s are around, so you can make a judgment and see whether you can make a decision whether the patient will get benefit, is fit and well, you can thrombolyze them. But the company says that you should go up to 80 and start from 80. Formal consent is not usually required. You discuss the options and risk and benefit, and usually if the patient is difficult to communicate, they have expressive dysphasia, they can't speak, next of kin can give you verbal consent. The first patient in Conquest site we thrombolized, I remember the lady, she was have expressive dysphasia. Then we have to, she was a young lady actually, and spoke to her husband and son, and then we thrombolized her. And the evidence is that you can give thrombolysis. In fact, not giving thrombolysis leads to more lawsuits in America than actually giving it, and patient developing complications. And you can give consent if you believe this is patient best interest. Just quickly, emergency CT scan while you're on call and you want to do CT scan can be a nightmare at times. So these are the indications for emergency CT scan. If you put that on your, the patient has these ones, then put these few lines, you're more likely to get CT scan very quickly. If somebody is being thrombolyzed, the protocol at Conquest and Eastbourne is that anybody who comes in should get immediately next slot for scanning. So thrombolysis is one of the indication for CT scan emergency. If somebody comes on anticoagulation with abnormal coagulation, you can get emergency CT scan. If somebody has started to deteriorate on the ward or when they come in, the GCS, you can get emergencies because they may be coning, or if they're developing hydrocephalus, that's indication for emergency CT scan. If patient is not eligible for thrombolysis, then you have excluded the bleed first, then first hour of immediate mean first hour of admission. When you say immediate scanning mean, you scan them within first hour, but we do scan here next slot. If patient is outside the window for thrombolysis, then what you do, you put them on aspirin 300 stat, and then you say you take aspirin 75 for two weeks after that. You can also use clopidogrel 75 for secondary prevention as well after giving aspirin stat or clopidogrel stat. If they can't tolerate either above, you can use diclofenac. This is just to recap, you can read it, that acute stroke thrombolysis, you should give aspirin, because 300 aspirin can be given PR as well. So if somebody can't swallow, you prescribe 300, they will still get it. But if you prescribe 75, you can't get PR. So you can, within 2 hours, you should give aspirin, and they are not dysphagic, you can give rectally as well. And thereafter, you should give 2 weeks in long-term aspirin therapy. But I think nowadays they use lots of clopidogrel as well. Allergic to aspirin, you can give them antiplatelet clopidogrel, and if you got dyspepsia or something, you can give proton pump inhibitors to aspirin. I tend to use pantoprazole when I use clopidogrel because potential interaction between the two drugs, but you can use omeprazole, which is standard drug in aspirin patients. And these are some, once acute stroke patient is thrombolyzed, you keep them nail by mouth and try to get NG tube within 24 hours. Major complication and mortality is associated with dysphagia related to stroke is aspiration pneumonia. You need to give them fluids. You check their catheters, usually catheters. You put it before thrombolysis. If not, then you can do it. You can use for alternative medicines. Salt review is very important, and salt assessment, nutritional assessment, and then decision whether to give them orally or NG tube feeding, and then after that PEG at some stage, and start early mobilization. This is just a general principles for stroke patients. And for ischemic stroke, in sinus rhythm, you use clopidogrel. As I said, should be the first line 75, and you can't tolerate, you can go for aspirin. And if you both cannot take aspirin clopidogrel, you go for diprodamol for that. So these are the sinus rhythm. If both clopidogrel are indicated, there is one trial which is called CHANCE trial where they use combination therapy for 21 days, and then you can carry on after that. I think some of the stroke unit do that. They use aspirin clopidogrel combination for 3 weeks, and after that, they let them all clopidogrel aspirin after that. I think I've seen 1 or 2 patients as well. And sometime in TIA patients, we do the same with high risk ones, for example. So coming back to the final slide of the presentation, learning points are, as we go back, anybody you suspect TIA, you should start aspirin 300 and refer them to TIA clinic, rapid access service in your area. They usually see them within 24 hours with a scan. And you must keep in mind, as I show you the different reasons and then presenting as a TIA, so you think of those conditions as well, and CT scan, some blood tests might help you in this regard. If somebody's got persistent logical deficit, you must send them urgently for brain scanning to exclude intracranial bleed, infarction, or brain tumor. Every suspected stroke should be assessed for thrombolysis suitability if the symptoms onset was less than 4.5 hours, and they should be considered for thrombolysis. So these are the 4 different areas which we have covered today. Any questions after that, guys? Okay, then are we happy to finish now this year? Okay, guys, thank you very much for coming, guys. Okay, thank you. Bye.
Thank you, Dr. Rahmani.